All right. We've got most of us here, I think. So let's start. Today we do the Cystic Fibrosis Project reports, and we have 10 groups, but one group will not be participating today. It's been deferred. So we'll start with the groups are numbered 1 through 10. We'll start with group 1. And since time is going to be limited, we won't have any feedback or commentary after each talk. We'll go straight from the end of one to the beginning of the next. And you should be shooting for 7 minutes. If you go over 7, I'll give you an alarm at 7, and that means you will have up to a minute to finish. So any questions or comments before we start? Okay, well, group number 1 is Casey Bostock and Ariana Watson. Casey, are you there?
I don't see Casey's avatar.
Okay, well, in that event, we'll go straight to group 2, which is Marcus Carabrook, Nahoma Gill, and Perla Ramirez. So is that group here?
Yes.
Yes, we are here.
Okay. All right, then share your screen with us, and it's up to you. Go ahead.
Okay, I'll share it right now. Is that on the screen?
Yeah, we got it.
Okay. All right, then I'll start. Hello, my name is Marcus Carabrook. This is our cystic fibrosis project. Our mutation is D1152H.
And I'm Perla Ramirez.
And I am Naomi Hugh. So first, we're going to start with the effects of mutation on protein structure. Our mutant D1152H is a type 4 of cystic fibrosis transmembrane regulator. And this mutation is associated with abnormal chloride gating. And under certain special condition, crossover and recombination between DNA strands can also lead to chunks of DNA being deleted or even added. These mutations in genes lead to changes in RNA and then changes in protein structure and function. So base changes are possible in DNA due to environmental mutations such as UV rays, X-rays, and certain chemicals. Now we have the effects of mutation on protein structure. No, sorry for that. The effects of mutation on protein function. And as already stated during DNA replication, the positioning of the correct base, it will get maintained. And if any mistake persists, that is being corrected by proofreading and repair mechanisms. And also it causes molecules to crystallize and distorts the shape of red blood cells.
Okay, now talking about disease symptoms from our mutation. Currently in the CFTR2 database, there are 556 patients with this certain mutation. Our mutation is a gating mutation, which can inhibit the CFTR protein from flowing chloride ions. Normally, the protein can form these channels for ions to regulate the flow of chloride ions and water molecules that go in and out of the cell. So our mutation can block these channels and prevent the flow of these chloride ions. Patients with our mutation can also be pancreatic sufficient, and this would require them to take a supplement that is a pancreatic enzyme to help mediate this. Patients with our mutation can also experience irregular sweat chloride levels, with average being 44 equivalent per liter. Our mutation can also lead patients to having a decreased overall lung function. As the cystic fibrosis develops, a patient's lung function can deteriorate over time, especially with age. These this decreased lung function can also lead to susceptibility to lung viruses such as Pseudomonas aeruginosa. And also cystic fibrosis symptoms vary greatly between patients. As we know, it's a hereditary disease. So children are born with this, but they may not experience the symptoms right away. And as age and time goes on, these symptoms can increase and decrease. So
All right, so possible cures or solutions for our mutation. So people with this mutation, it can be screened through chloride testing since it's associated with abnormal chloride gating. Most of the descriptions of the medications that I'm going to talk about the F508del mutation, which is more common since only 2.9% of cystic fibrosis patients have this mutation. And these are all 3 medications that have been approved for treatment for patients that have our mutation specifically. The first is Kalydeco. This one binds to the defective protein at the surface or at the cell surface and opens the chloride channels to keep it open so that the chloride ions can flow through, and that regulates the amount of fluids at the surface of that cell. And that's usually used on patients that are younger, like between 4 months and up. Then we have Trikafta, which is a triple combo medication. And it's used in patients that are 12 years and up. This helps the F508del CFTR protein form like its proper shape so that it can traffic and move through the cell surface. And this one can also be paired with Symdeko, because when it is paired, it helps the CFTR protein perform better than other modulators for like more people that have cystic fibrosis. And then Symdeko on its own is for patients 6 years and older. And it helps the CFTR protein form the right shape and move through the cell surface and stay there longer. And it also has the least side effects than all of the other correctors and combos that we're talking about, specifically chest tightness, which is one of the biggest complaints that people have with these medications. So yeah.
Mm-hmm. And then just to the, oh, go ahead.
And then next is just our site page.
Correct. Yeah, and that's just our works cited. I was just going to go back to this and say that the images that we had were to the right are just the listed cures, and the dosages are given under it. But that is our works cited, and that is all for our presentation.
Okay, you're on time. Thank you.
Thank you.
In the meantime, I think I saw Casey come in. Is that right? Casey, are you there?
Yeah, I'm here.
Okay, you were number 1. Would you like to go now?
Yeah, I can do that.
Okay.
Mm, do I just share my screen?
Yeah, just click on the green button.
Okay. Okay. And then Mm. Oh my gosh, sorry, I forgot how to start it.
Just hit present
It's
over to the right, on the right side of the slide.
thank you.
Next to share.
Okay. Just gonna move that. Okay, so me and Ariana have the mutation A455E. Today she had an emergency, so she couldn't be here to deliver her slides, but I'm gonna do my best and try to read off of hers for you guys. But yeah, I'll go ahead and get started. So as I said before, my group's mutation is A455E. This is a class 5 mutation and it is a decently mild variant. I went ahead and went with this picture because I thought it showed really well the class 5 mutation, and it even uses our mutation as the example for class 5. So yes, and then how do I change slides? Oh, okay, that works. All right, so the effects on protein structure. First, I will go over the normal production of CFTR, the CFTR gene without a mutation. The CFTR gene location is 7q321, and the protein is made up of 1,480 amino acids. A normal CFTR protein is created starting within the nucleus. First, pre-mRNA is created from transcription after the sequence of the gene has been replicated. Then proper splicing occurs where introns are taken out and exons join. Translation then follows where the amino acid chain forms a polypeptide, which then forms the CFTR protein. The protein travels to the endoplasmic reticulum to be folded and packed. Then it is sent to the Golgi apparatus and then to the apical membrane. The CFTR protein is used at the membrane to form chloride channels to allow the active transport of chloride ions to maintain the balance of salt and water. A mutation in the gene or the blueprints of how to make the protein usually leads to a change in a protein structure. Proper protein function relies heavily on the shape of the protein. Mutations typically change the structure of the protein, which has an impact on the function. Our mutation affects transcription, which leads to improper splicing. This allows incorrect amino acids to be in the chain where they should not be. The mutation A455E is a missense mutation that leads to a change from alanine to glutamic acid in amino acid residue 455 of CFTR protein. The mutation is situated in the first nucleotide binding fold and may interfere with the binding of CAMP to the CFTR protein. CAMP drives and supports the chloride-gated channel. This change in structure leads to a change in function. And that brings me to the next slide. So the effect on protein function. The mutation A455E is a class 5 mutation. This means that the normal CFTR proteins are produced, but not enough in quantity due to the lack of transcriptional regulation. The mutation influences the splicing machinery or the mRNA processing. It generates both normal and abnormal RNA, mRNA. As previously stated, transcription is affected by the mutation, which means incorrect amino acids take the spot in the polypeptide. So once the protein is sent to the endoplasmic reticulum, there ends up being problems when folding occurs in many different locations. It affects the alpha helice and the beta pleated sheets when being folded. Spliced variance causes a reduced, spliced variance causes a reduced number of functioning CFTR proteins in the plasma membrane of the cells. Not enough CFTR proteins means there is a buildup of chloride within the cells, and water cannot hydrate the cellular surface. This leads to a mucus covering the outside of the cells. This affects the movement of cilia, which then causes problems in other places in the body. This mutation is situated in the nucleotide binding domain 1, and it is a common mutation. And then I went ahead and chose these photos. I chose these photos because I feel like it highlights what is going wrong when the mutation is, apparent or there. The first image is the apical membrane. As you can see, the image is a well-functioning membrane, but when our mutation would be there, it would be in the oh my gosh, sorry, I can't speak. It would be in the spot labeled NBD1. And so it happens to be in an early process of the protein reaching the apical membrane. And I chose the second picture because it's class 5. So that typically means that there's intron splicing and it's incorrectly doing that. So yeah, this was my portion so far. So I'm gonna move on to Ariana's. So she had these.
You're at almost 7 minutes now.
Oh, geez. Oh my gosh. I'm so sorry. So these are her symptoms. The CFTR protein is degraded, so it was easier for the symptoms to show up and make it harder to treat. Cystic fibrosis is obviously a symptom. Pancreatic function and residual secretion of chloride ions across the membranes. Mild pulmonary disease, diabetes mellitus. Patients with the mutation have a better prognosis than patients who are homozygous for the delta F508 mutation. And then she chose this picture, levels of the A455E and what exactly it looks like in, I would say she said strip format or something like that. Symptoms, treatment of the cell with proteasome inhibitors. It also can be rescued by the transcomplementation in a mature C-band. Transcomplementation was to show that if it can enhance the protein process and how that would work in the mutation. The compound correctors of C3 and C4 also rescued A455E. MG132 and PS341 were 2 treatments for our mutation. Proteasome inhibition increased both immature B and mature C bands. And then she said for her pictures, the lighter shaded area in the second row is the A455E. When looking for A455E mutation, it would be the more lighter color than any other shade. But yeah, and then we have the works cited. So that was it. Sorry about that.
Okay. So let's go to the next, if you take your slides down, we'll go to the next group, which is group 3, Zach, Jante, and Mastura.
We're waiting for Jante, so if we could come back to us, that'd be great.
All right, then let's go to group 5, because group 4 has been deferred. So group 5 is Dylan and Miguel.
Alrighty. I'll share my screen. Okay. Can you guys see everything?
Yeah.
Alrighty. So, hi, my name is Dylan Strangman, and I'm here with Miguel today to talk about the mutant gene G551D. Let's get right into it. So, there's a couple peculiar things about the mutant before I start talking about the science portion of it. Being regarded as one of the most prevalent mutations, although it's not considered one of the most prevalent class mutations. So it's kind of like an outlier to all the other mutations that are around. And about a little less than 3,000 patients have this variant, and mostly located in Northern Europe because it's correlated to this thing called the Celtic gene, which is typically the mutant gene and the Celtic gene go hand in hand. It's like a nickname for it, but I only separate it because there's other diseases involved in it. Although just because you have the mutant gene itself doesn't mean you have the other diseases. And typically the main disease besides cystic fibrosis is going to be hemochromatosis, which is an iron overload in your blood. So your body can't actually dispose of the iron itself. So you develop arthritis very quickly on in your life. Moving on to protein structure difference. The CFTR protein mutation really just causes a missense where just one base is replaced to change the glycine amino acid aspartate to position 551 in the MBD1. So what that causes is I circled right here. Oh, sorry about that. It right here is where it starts being mutated, and there's only one amino acid change. There's really not much else that happens. It's a very simple mutation, but it causes a lot of issues with the CFTR protein itself. So with the function difference, it's a class 3 mutation, which basically means that the protein is made. It's practically full functional. It's not disformed at all. But once it gets to the cell surface, it can't do its job. And the reason why for this protein is because in MBD1, what happens is ATP is completely abolished. So any ATP hydrolysis function can't be used at all, which essentially just means that it's close all the time. And so the chance of it opening at all is 100 times less compared to a typical CFTR protein, which causes constant chlorine buildup to the point where it kind of acts like a faulty dam where you can't really let your water in or out at all. It just kind of stays static. Moving on to the effects of this mutant itself, there's a pretty high chloride content compared to other cystic fibrosis mutations. And the only reason why I brought this up, even though it's considered a diagnostic test, it shows kind of over here how the chlorine itself can cause the increased mucostasis to occur, which basically means that the little cilia right here can't actually pick up the mucus itself because of the chlorine's because the chlorine isn't active, it's not outside of the cell. So what happens is the layers of mucus become thicker. And on top of that, because chlorine is there too, the water lining of the channels where the cilia are completely like dehydrated. So that causes thicker mucus, and it's basically kind of like almost oobleck or concrete in like any channel way that has mucus. And that's especially occurrent in the lungs and the pancreas. Now, starting off with the lungs, it's kind of a gross picture, I'm not gonna lie, but that's actually the autopsy of someone with the G551D lung with both the Pseudomonas infection and the mucus buildup. So as you can see, the yellow portions are actually where the mucus is, and the black spots are where the bacterium infections occurred. So with this effect, poor lung function is gonna be probably your most dominant case here with breathing troubles, and it's almost as if like you're drowning in mucus constantly, coming back to that oobleck concrete statement from earlier. And then 60% of the time, people who have this mutation are prone to get infections sometime in their life. And that causes, specifically with the Pseudomonas infection, prolonged inflammation. And although it's treatable, by the time you do treat it, it's practically already back. It's almost like a constant cycle of treating and then it coming back. And then with the pancreas, this is probably one of the most damaging portions of this mutant because 94% of all people who have this mutation are prone to have completely insufficient pancreas. And that's because of the lack of digestive enzymes with a mucus block. So as you can see right here where I circled, because of the mucus plugs from the mucus buildup with this particular mutant, you see that it actually intrudes on the pancreatic duct and actually builds a wall essentially. So all the pancreatic duct and the pancreas can do its job and release the enzymes. So overall, these symptoms can kind of show how this mutation, although very simple, can cause major severe. It's what I like to call like a very severe CF, almost like a much more damaging, even though cystic fibrosis itself is very damaging.
So for the effective treatments, there are three. There's Calitical, Symdeko, and Trikafta. Each one contains ivacaftor, which helps the channels open, at least open longer. It increases the protein function, but it doesn't make extra proteins to reach the surface. It's only been tested in the current range so far for each one. Calitical is for 4 months, is like the youngest it's been tested on. Each one is almost or about 1 dose for every 12 hours. And each one said like to not eat grapefruit. And it says like they're not recommended if you're pregnant or plan to be pregnant or breastfeeding or plan to be breastfeeding. And each choice is recommended. You have to talk to your doctor about it. For Calitical, there's 2 forms. There's the pill form for 6 and older, and then there's the oral granules for the infants. You take them with food, with high fat foods. These are the common side effects that you'll probably see between the this one and the other 2. Oh, you could slide to the next one.
Oh, my bad.
So then, Symdeko, this one has tezacaftor and ivacaftor. Tezacaftor helps bring CFTR proteins to the cell surface, or helps it reach the cell surface more, while ivacaftor is helping the channel stay open longer. There's 2 types of dosage for this one, depending on your weight or the children's weight. And then this one again is 1 pill in the morning, and then 12 hours later, another pill. Is it this one? Yeah. So with this one, they did a forced expiratory volume measurement, which measures how much air a person can exhale in a forced breath in 1 second. And in a 24 weeks test, there was an average lung function increase by 4%. This one, doctors will do more blood tests, since some people that take it end up having high blood level or high liver blood levels. So like they just have to test your liver or
Miguel, you're right at 7 minutes.
Okay. And then the next one, Trikafta. This one is with alexacaftor, tezacaftor, and ivacaftor. So alexacaftor, this is like a 2.0 of tezacaftor. It's considered the next generation for it. This is the first product that's been approved to treat cystic fibrosis in approximately 70 to 90% of all cystic fibrosis patients. It's the first one to have 3 components to help the CFTR proteins function better. This one you have to take 2 in the morning and then 1 in the evening. That's pretty much it. Oh no, this one, so on the average 24 weeks, there was a lung function increase of 14.3% in the forced expiratory volume test.
So everyone in the science field calls this the model mutant because of its research for both Trikafta and ivacaftor, which is just an active ingredient in Trikafta. with more clinical trials on the way, and it also improves sinus medicines. And this mutation just doesn't only affect class 3 mutations, but all of these medicines also correlate to other mutations. So with that said, it's an energy deficient mutation with extremely severe symptoms. It's primarily treated with drugs. Rarely, sometimes you will need enzyme supplements because of their pancreas, but it's very expensive with $300,000 per patient per year. Life expectancy at the moment is just 44 years, but that was found only 3 years ago when Trikafta was just on the rise. So people expect it to be much higher, probably in the 60 or 70 range, with improved life quality, almost close enough to consider a healthy life, and CF research increasing rapidly due to this mutation. Thank you.
Okay,
Alrighty.
very well. Zach, are you ready yet, or do you want to wait longer?
I believe we have everybody here. Jonte, you're here, right?
Yes.
And Mastura, you're here?
Yeah.
All right, I believe we have everybody.
Okay, go ahead.
One second, I'm having technical issues. One second here. Unmute. All right, there we go. I was trying to hold space to unmute, and it was just rapidly cycling through. Anyway, so hi, I'm Zach. Mastura and Jonte are here. They helped me with the project. We got the R117H mutation, which, as you can see here, is a milder form of a CFTR mutation. So first off, we're going to be moving into general information, and I will pass that off to Jonte real fast.
Hi, it's Johnson here. So general information about R177H is mutation is generally considered to be a mild CF class 5 mutation. Also, when combined with another CF using its association with broad phenotypes ranging from CFs with supportive disease to no clinical disease. Also, this missense mutation has a mixed conductance, class 5 and gating class abnormalities, which lead to severe loss of CFTR channels. And that's it.
Okay, awesome. Thanks so much. So first off, we can move into some of the function changes of the protein. First, we need to say that there are submutations of R117H. They are based off of the poly-T tract, which is known as the polypyridamine tract. It's used to anchor spliceosomes. There are 3 different subtypes, 5T, 7T, and 9T. The 9T variation is not known to cause cystic fibrosis almost ever. So we have excluded that, but just know that it does exist. So in general, the chloride secretions of people with this mutation are actually higher than 20% normal. And that is in contrast to the fact that only about 10% of the protein is functional. It doesn't tend to impact nose or intestinal secretions, but what it does do is it affects the function of the transmembrane domains. So the walls of the protein versus the nucleotide binding domains, which is where the energy is input. We can get into a little bit of data analysis here. So for people with this mutation, chloride conductance is actually really high. It's 70 to 85% normal, well, higher than that. But of that reduction of 30 to 25, 15%, I can't math. About 72% of that is because of a reduction in channel open probabilities versus about 14% being from poor conductance. So in other words, it's just not open as much rather than the chloride being able to get through. So we had found in our research that AMP-PNP, which is an ATP analog, meaning that it should act similarly to ATP, it doesn't tend to lock open CFTR. So the authors of that study came to the conclusion that R117H tends to compromise the lock open stability of the protein. And that they also put forward a possible reason for this mutation's mildness. It's that the cell overproduces the protein to make up for the loss of function. So let's say 1% of a normal wild type CFTR gene, or excuse me, sorry. If a normal CFTR gene only puts out 1% of the entire cell membrane, this could do like 5%. We don't have numbers, but that's sort of the general idea. So now we can get into the actual effects of the mutation. In general, the balance of the water and the chloride in and out of the cell are disrupted. So it's poor flow of salt and water in and out. And that results in the lungs with thick, sticky mucus, lung infections, and lung damage. And in the pancreas, that you also get thick secretions, blocked ducts, infections, again, more damage. And because it's the pancreas, it sort of reduces the ability for the body to break down and absorb food. Generally, with our mutation, life expectancy is only about 41 years, but that's not terrible. So now, as you can see here, we've got our 5T and 7T mutations back. In general, 5T is much worse than the 7T mutation, but either way, you don't want either one. In general, as you can see, the sweat chloride is almost twice as bad in 5T than 7T, but in all cases, after about age 20, lung function drops off a cliff. So for normal people, it's 80 to 120%, but for both 5T and 7T, you're down to 36 and 62%, which is not great. Pancreatic insufficiency for the 5T is over twice that of the 7T, and almost 6 times as bad for the Pseudomonas infections for the 5T than the 7T. Now, not all as bad. We can talk about some of the treatments that there are. VX770, also known as ivacaftor or Kalydeco. That is one. It tends to shorten the closed gating time and extend the open burst time. So in other words, it's not closed as much. And when it is open, it stays open for longer. There's also nitrate and DPATP. They also function similarly. They act as CFTR potentiators. The VX770 interacts at the lipid protein interface, whereas the nitrate interacts at the water protein interface. From some of the research we had found, all 3 of them together, the ivacaftor and nitrate and DPATP almost completely rectify the gating defect. I should probably mention that DPATP is N6-2-phenylethyl 2', deoxy-ATP, which is just a different form of ATP analog. You can see that over here on the right. There's also VX809, which is lumacaftor, which also acts as a CFTR potentiator. Also, the IRBIT and NERF1 can also work to increase conductance, but they're not drugs. They are actually expressed proteins. So IRBIT is inositol 1,4,5-triphosphate receptor binding protein. And then NERF1 is sodium hydrogen exchange regulatory factor 1, which is a type of scaffolding protein. IRBIT decreases the mean close time, and NERF1 drives dimerization, which increases the open probability. So it does something similar to ivacaftor, where it's closed less often, and when it's open for longer. So here's an example for treatment with Kalydeco. You have the drug itself, and it helps people by, like I said, forcing the gate to stay open for longer, which allows the chloride to move through the channel more easily and more of the chloride to move through. It reduces the symptoms in general, and it is approved for use in patients aged 4 and older. As you can see over here, this is sort of an example of normal CFTR protein, with a class 3 defect, which ours was 3-4, but it can work similarly. And then with Kalydeco, here's our works cited pages. And just wanted to thank you all for being here. And it's been a great semester. Thanks so much.
Okay, thank you. So that was group 3. And now we go to, let's see. We've done group 5. So group 6, Brian Yee, Donald Edwards, and Esteban Monzon. Are you here?
2 of us are here.
Okay.
Can you guys see that? Yes.
Okay, so our mutation was the R347P. Presentation is presented to you by Donald Edwards and Brian Yee. Moving to our first slide. Protein structure and function. R347P, the original amino acid is arginine. Its position is 347, and the new amino acid is proline. It's located in the first membrane spanning domain. This is both a class 2 and class 4 mutation because it's misfolded and it lacks function. Traditionally, class 2 mutations are misfolding, and that's an abnormality that prevents the achievement of a healthy functioning state. And class 4 is protein moving to the surface, but the chloride transport channel is defective. Severely misfolding results in not leaving endoplasmic reticulum efficiently. And defective chloride transport level, 30% of its wild type conductance. Wild type is a strain or gene or characteristic that prevails among individuals in natural conditions, but obviously this is a mutation. Its function, it lacks function, so the protein has trouble moving to the surface. The protein in this mutation is 15% as effective as those of the wild type. So moving to the diagnosis, the chloride levels, elevated sweat chloride, just for a rule of thumb, the higher the chloride levels equals cystic fibrosis. Normally, the concentration of chloride is less than 60 milliequivalents per liter, but in this mutation, it is 98 milliequivalents per liter, which is significantly higher. So that would classify this as a severe case of cystic fibrosis. Going on to our symptoms. Out of 515 patients in the cystic fibrosis database, about 257 or 65% of them are pancreatic insufficient. The pancreas is unable to produce or transport enzymes that break down food in the intestines. Patients would need to supplement pancreatic enzymes to replace the enzymes their bodies cannot produce naturally. Lung function, if you refer to our chart, a pulmonary function test is used to measure lung function. Normally, it is about 80 to 100%, but in this one, the values are lower, and the lung function decreases over time. Lung infections affect 55% of the patients in this, and the patients that suffer from this mutation. So that's about 141 patients. They're prone to severe lung disease, such as the mutation progresses, specifically pneumonia, which is bacteria that causes infection in the blood, lungs, and it requires specialized antibiotics. Moving to our next slide, this is treatments. So Symdeko is a combination of tizactophore and evectophore. Evectophore helps the cells stay open longer, while tizactophore brings more CFTR proteins to the surface. It allows more chloride ions to pass in and out of cells, and it balances salt and water in lungs. If you can see by our illustration, with the evectophore, it helps the proteins to stay open longer, and then the Symdeko, the tizactophore, brings the proteins to the surface. I thought the illustration would help give us a visual representation of what the medication does. There are side effects to this though. The more serious side effects are high liver enzymes in the blood and abnormality in the eyes. And the common side effects are headache, nausea, sinus congestion, and dizziness. We move to our next slide. Trifacta, that is a triple combination of elaxtophore, tizactophore, and evactophore. The elaxtophore and tizactophore helps the proteins rise to the surface, as you can see by our illustration. And evactophore helps those proteins stay open longer. And this is recommended for patients 12 ages and over. As with the other treatment, there are serious side effects as well, which are high liver enzymes in the blood, abnormality in the eyes. But there are far more common side effects such as headache, diarrhea, common cold, stomach pain, inflamed sinuses, and liver enzymes, increase in certain blood enzymes, rash, and in some cases, the flu. And our next slide was our works cited. So that's all we have for our presentation.
Okay, you're well within the time limit. So we'll go to the next group, group 7. And that is Mary Kitt, Haley Garrett, and Larson Isia.
Can you see it?
Yeah.
Okay. So our mutation is I507del, and we have Mary, myself, Haley, and Larson. So what is a CFTR protein? CFTR stands for Cystic Fibrosis Transmembrane Conductance Regulator. This protein is found on epithelial cells and helps balance sodium, chloride, and water. ATP pump, which means it uses ATP to move ions. As the ions move, the water follows as osmosis occurs. Specifically, chloride actively, and due to an electrochemical gradient, the sodium follows passively, in which the water follows due to osmosis. ATP uses energy to move chloride due to opposite charges. Sodium follows chloride. The water flow helps break up mucus. The mucus is normal and helps with things like dust and stuff like that. But when it starts to build up, it isn't normal anymore and is like part of the reason cystic fibrosis patients have symptoms like coughing or shortness of breath. And then what is a mutation? A mutation is a change in a DNA nucleotide sequence. Rarely that change will be beneficial, creating something better or more efficient than what was actually supposed to be made. So how I507del affects the protein structure. It is a class 2 mutant, which is the most common class regarding this protein. This mutant causes a deletion of 3 nucleotides, isoleucine codon, which codes for amino acids. This faulty amino acid can be thought of as a building block for the protein. Ultimately, the protein will still be built, but it does not allow sufficient ion flow, if any at all. And then in this photo, can you see my little mouse?
We can.
Okay, so the green is sodium and the little blue one is chloride, and this big one down here is ATP, and then these orange ones are the cell membrane. So ATP isn't working here. It's blocking the channel or the pathway. So the ions can't flow through, and because of that, water isn't flowing sufficiently. Because of osmosis, the water follows the ions. And so therefore there's a mucus buildup, and the water doesn't necessarily need the channel, like it flows regardless, but without the ions flowing, it has nothing to follow, so it's not as much as it should be. So therefore the mucus builds up, because like the mucus would build regardless, but it's too much when the water is not flowing and there's the blockage.
The protein in the mutant controls the entry of salts and water balance in the cells. After the making of the protein by translation and transcription, the transmembrane protein moves to the surface of the cell Here it functions as chloride channels to allow entry of salts into the cell. This mutant belongs to class 2 type mutation, where there are misfoldings of the mutation protein causing impaired trafficking problems. Therefore, it cannot come to the surface to function as a transmembrane protein. Also, the function of the transmembrane protein channel to allow chloride ions to impair. It leads to accumulation of water and salt outside of the tissue, causing cystic fibrosis. The protein channel pore opening is mediated by the phosphorylation of its cytoplasmic regulatory domain and by ATP binding at the nucleotide binding domain, which induce conformational changes allowing anions to flow. Protein folding principles involve compaction of extended polypeptide. Many of the remains that are distant in the primary structure are brought into close proximity as native structure is acquired. The protein is embedded in a lipid bilayer, and construction co-translational folding intermediates play an important role in the mechanisms of de novo protein folding and raise the possibility that they contribute to molecular pathology of protein folding disorders.
For treatments, the treatments range from breathing techniques to a lung transplant, although a lung transplant won't cure the disease. The reason they have transplants is because there can be permanent lung damage from the mucus buildup, and it will get increasingly harder to breathe. But even after a transplant, the patient will still have to treat their cystic fibrosis. So the treatments to treat it are Orkambi. It's a drug specific to this mutation, which works in a way that allows the protein to fold in a more correct manner. The second is Kaftrio, another medication which helps the protein make it to the surface, as well as helps the channel function properly so the ions can flow properly. And then there are dilators, which are basically steroids or an inhaler or even some type of breathing treatment where you put liquid medication in and then like inhale it to help open up your airways. And then of course there's just general medication for cystic fibrosis. And then here's the works cited.
Okay. Thank you. We'll go to group 8, which is Marissa, Cardinia, and Alamara.
Do I just share my screen? Let's see. Okay, can you guys see my screen?
Yes.
Yes. Okay.
Okay, so hello everyone. Today we're presenting cystic fibrosis mutant N1303K by Cardinia Elia.
Marissa Loera.
Annalie Merida. Introducing the N1303K mutants. N1303K is a class 2 trafficking mutation. It can cause folding of the protein mutation and consequently result in absence or reduced quantity of CFTR protein. The N1303K allele is a product of missense mutation in exon 21 of the CFTR gene. It causes amino acid changes in the NBD2 of the CFTR protein. 88% of people with CF have at least one mutation in that class. It is one of the most common severe disease-causing mutations in the CFTR gene. It causes both defective biogenesis and abnormal gating of the CFTR protein. The mutants show abnormal responses to ATP analogs or mutations. It's abnormal to ATP analogs or mutations that disrupt ATP hydrolysis and or dimerization in CFTRs to nucleotide binding domains. It is located in SCFTRs and BD2s, which plays a critical role in controlling ATP depending opening and closing of the channel.
The effect of the CFTR mutant on N1303K on protein function. The CFTR gene contains the instructions for making the CFTR protein. In the CFTR gene, the class 2 mutant N1303K causes the CFTR protein to misfold and not be made at all. But if it does get made, there will be a gating malfunction and will not function properly. A gating malfunction means the chloride ions can't travel through the channel as it's supposed to. The CFTR gene creates protein, but the mutant N1303K creates misfolds, which prevents the protein from moving to the cell surface. It prevents it from processing through the endoplasmic reticulum and Golgi apparatus properly, so therefore the protein never goes to the cell surface. The mutation in the CFTR gene disrupts the function of the chloride channel because it does not make the CFTR protein correctly, which prevents the usual flow of chloride ions and water into and out of cells. We now understand how the protein is made. Scientists have been able to develop treatments that target the protein and restore its function.
Effects of the CFTR mutant on protein structure. Researchers are still trying to learn more about the structure of the CFTR protein so that they can find new and better ways to help improve the function of the protein in people with CF. The CFTR protein is composed of 1,480 amino acids, which is the building blocks of all proteins and is located on the surface of many cells in the body. The CFTR protein contains a single chain of amino acids that are grouped in 5 functional regions called domains. 2 transmembrane domains, 2 cytoplasmic nucleotide binding domains, and a regulatory domain make up the CFTR. Each domain has a special function when it comes to transporting chloride through the cell surface. Therefore, mutations in different domains cause a range of CF symptoms depending on the extent that chloride transport is affected. Mutations in CFTR often affect the 3-dimensional structure of the protein and prevent CFTR from reaching the membrane.
Okay, symptoms caused by the cystic fibrosis mutation N1303K. Upon doing my research, I came across the fact that no matter what mutant of cystic fibrosis someone had, those infected showed similar symptoms. Not many people know, but cystic fibrosis affects both the respiratory system and digestive system. CF affects the respiratory system by creating mucus that blocks air sacs known as the alveoli in the lungs, which is when people start showing respiratory symptoms like a persistent cough that produces thick mucus or phlegm, shortness of breath, recurrent lung infections, a stuffy nose, or wheezing. CF affects the digestive system by creating blockage in the pancreas and bile duct, affecting the enzymes from reaching the small intestine where food is digested, and that causes people to show common symptoms like a greasy, foul smelling stools, constipation, nausea, a swollen abdomen, loss of appetite, poor weight gain in children, and delayed growth in children. I've included two images. The one on the left shows an illustration comparing a normal set of lungs and a set of lungs infected with cystic fibrosis. And the image on the right is comparing a normal digestive system and a digestive system infected with cystic fibrosis. Possible treatments for mutant N1303K. Due to the N1303K mutant creating misfolds, a common treatment are correctors like lumacaftor, which is the drug that helps the defective CFTR protein fold properly so that it can move to the cell surface. I've incorporated an image on the bottom left. Another issue that this mutant creates are gating problems, which is common treatments are potentiators like ivacaftor, which is a drug that helps open the CFTR channel at the cell surface and increase chloride transport. I've incorporated a image of some common medication on the bottom right or left. Before I lose your attention, I'd like to discuss something interesting I came across my research, which is the Lebanese population. So studies show that the Lebanese population had the highest percentage of cystic fibrosis with the mutant N1303K. It's believed to have come from their common consanguineous marriages, which means that they're marriages with people who share common ancestors. A family member, which is like a family member. So a study in the 1977 was conducted to study the CFTR mutational spectrum of the Lebanese population, where 36 alleles were tested and tested again in the 2000s, but with 44 alleles. And 27% of the 44 alleles were the mutant N1303K. I mentioned this because scientists were able to do studies like splicing, incubating cells, and comparing the mutant to different tests, which is where they came across potentiators and correctors. This is just a little bit about the Lebanese population and its association with the mutant N1303K. But that's all I have for you guys today, and thank you for your attention.
Okay. Good. The next group, group 9, is Cesar, Laith, and Leisha.
Yeah, let me just share my screen. It's not lit. Can you guys see it?
Yeah.
All right, so we got mutant R553X.
Cannot see that. No, we don't see it.
Oh, you guys don't see it?
No.
It looks like the professor's the only one that's seeing it.
Can you see it, Professor?
Yeah, I can see just your avatar.
Yeah, we're not seeing the presentation itself.
Oh, snap.
Did you click the green button that says share screen?
Yeah, share screen. And then
Nope.
just share. Is it working now?
No.
Nothing changed for me.
That's weird.
Click
Can
on blue share.
yeah, share.
Yeah. blue button. Share.
Yeah, it's not. I keep looking share. It's not doing anything else.
Sometimes there's a different window that pops up and it asks you what you want to share exactly. So see if that popped up maybe.
Might have popped up in the background. Yeah.
Yeah.
We'll basically show every single one of your windows that are open.
Yeah, can you?
One of my other group mates share it too. I don't think it's now the Zoom thing is even popping up for me. Oh, here we go. Caesar, Laisha, can one of you guys share it?
Yeah, I'll do it.
Technical difficulties are oh so fun.
But inevitable. Okay,
There we go. Now we can see it.
All right, so we have mutant R553X.
All right. Effective R553X on protein structure. It occurs in exon 11, and there have been evidence that so that stop codon mutations possibly lead to a total absence of CFTR protein, and it can also produce a truncated protein missing the regulatory domain in the second nucleotide binding fold and the second transmembrane span, leading to a reduction or absence of cytoplasmic CFTR mRNA. Like I said, the evidence that suggests this means that the CFTR protein in airway cells may be less damaging than the presence of an altered protein. But why does the missing regulatory domain matter? Because the phosphorylation of serine residues in the regulatory domain is a prerequisite for opening the CFTR canal or channel. The nucleotide binding fold matters because the fold is used for the binding of nucleotide cofactors, but it can also help with substrate binding. And the missing transmembrane matters because the transmembrane protein functions as gateways to allow the transport of specific substances across the membrane. Stop mutations like R553X cause the skipping of exons that the mutation is in. There are two different mechanisms that have been proposed to explain how stop mutations cause exon skipping more often than other types of mutations. The first mechanism is known as nonsense associated alter splicing, or NAS. This could involve a scanning process that monitors the open reading frame for PTCs, or premature termination codons, before splicing occurs, promotion skipping of the exon in which the PTC is located. The second proposed mechanism, which is also supported by more extensive evidence, involves the inactivation of exonic splicing enhancers, or ESEs, which are short and degenerate sequences that promote the selection of proximal splice sites and constitutive and alternative exons. And in some cases, the mutated mRNA is unstable and does not produce the CFTR protein. In other cases, abnormal protein will probably be unstable and degrade quickly. This is what produces the protein with the deviant sequence.
The disease symptoms caused by R553X, it can, as you know, cause cystic fibrosis when combined with another cystic fibrosis causing variant. It can also lead to a pancreatic insufficiency when combined with when there's another similar variant present. There is also an increase in sweat chloride seen as taken in records of people suffering with this sort of symptom. And then lung function can suffer and be impaired if they have the mutation.
This mutation can lead to bacteria to build up in the lungs and form what is known as Pseudomonas aeruginosa, which is seen on the bottom right. Next slide. So possible treatments for the symptom. You could use CFTR modulators, which can be used to target the CFTR defects. Gentamicin, which is used for cell treatment and basically kills bacteria, or it can also stop the growth of bad bacteria. Adalurin has been used to improve lung function, and a little fact is you shouldn't be taking gentamicin with Adalurin. So definitely talk to a doctor if you are maybe taking any of those. And then next is amylinoxin, which is used to increase the mRNA transcript containing the stop codons and the full-length CFTR protein. You could also use the CFTR potentiators, which are used to modulate the CFTR function in the plasma membrane. And then IVA factor, which has been the most successful form of treatment, has been able to find the initial identification of the error immediately, and it helps open the channels longer and increase protein function, as well as there's been gene therapy, which has been proven to correct all CFTR mutations.
Okay, is it possible to screen people for the presence of the R553X mutation? It is possible to get a screen test for this mutation, and in order to receive a test, it must be confirmed by the patient and its parents that they are all homozygous towards it. And an article that I read that I will also be discussing in the next slide is that both of these parents were both tested, which resulted in the child having this mutation. And the screen test is done like any other cystic fibrosis screening test, which is just measuring the salt in the person's sweat. And this test is not diagnostic, but it does detect any health disorders in the person who show no symptom. And the picture on the right is actually an example of one of the screening tests done that detected the R553X mutation. And then next slide. What percentage of the population with the cystic fibrosis carry the R553X? So this mutation is one of the many mutations in cystic fibrosis, which is why most of the side effects that it causes are very similar to the ones you find in cystic fibrosis. The R553X accounts for only 1.1% of the cystic fibrosis chromosomes, and it's mostly found in only Caucasian populations. So the article that I had read, it discussed, it was talking about a 3-year-old Taiwanese boy who was actually found to have this mutation. And many doctors and researchers were very shocked to find this in him because, like I said, the majority of the people who have this mutations are either from European or North American descent. And I found more evidence.
Excuse me, you're at 7 minutes, Leisha.
Okay. And then I found more evidence of these tests that were made, and it was made in a small group of people that it showed that only 1.13% of the people had it, while 90.8% did not have the mutation. And then out of the whole population, only 22% of people with the cystic fibrosis have the R553X. And then very quickly, the pictures on my right comes from the test that was done on the 3-year-old Taiwanese carrier. The first one on top, it shows what they had found in his body. And then the one at the bottom is the test made on both parents and the patient, showing why they all have it. And yeah. And then that's just our works cited.
Okay, thank you. Now we go to group 10. Zach and Agarid.
Hello. Agreed, you're muted, by the way. Wait, can you hear me? Hello?
We can hear you. We can't hear Agarid.
Oh, sorry. I don't know what's happened.
All right.
Are you hearing me now?
Yes.
Yeah, we're hearing you now.
Sorry, so sorry. Hi, everyone. My name is Agarida Yusuf, and my group number is.
I'm Zachary Smith.
So our mutation is W1282X, which is happen in cystic fibrosis protein. CFTR. CFTR is a cystic fibrosis transmembrane conductor regulator, is responsible for the disease of cystic fibrosis. It's a member protein, function as a transport channel for chloride ion in epithelial cells around the body. W1282X, it's classic 1 mutation because of the nonsense mutation in the CFTR genes that causes early termination of protein synthesis due to the early introduce of stop codon. So we have guanine, it's been replaced with adenine. W, it's referred to the tryptophan, UGG, and it's been replaced to UGA, which is stop codon. And this is what caused the mutation. 85% of the people who has this mutation, they are Ashkenazi Jewish.
So our mutation, W1282X, causes a truncation in the cystic fibrosis transmembrane conductance regulator, which causes the CFTR polypeptide to not generate regions of the nucleotide binding domain 2, or NBD2, past location 1282, which either prevents the protein from forming entirely or causes the protein to be inactive. Nonsense mutations are a result of the presence of the premature termination codon, or PTC for short. The cystic fibrosis transmembrane conductance regulator is susceptible to nonsense mediated decay, which causes the CFTR to produce a shorter protein than is usable, or that is unstable, sorry, and lacks normal channel activity in patient-derived tissues. The picture to the right shows a normal protein, but what our mutation would do is it would cause the NBD2 part of the protein to have a stop codon, or making it so it doesn't form at all, or it's not fully formed. Okay, let's next slide.
Yeah, so we might have an absent protein, and we don't have protein at all, or we have might have a protein, but it will be a partial. As we explained in the previous slide, we missing this part in BD2. So we will not have CFTR phenotype severity because we will the function odds will not work in either way. So what it does, these two functions, they are responsible for opening and closing the protein. In the muted NB, this part in NBD2, ATP is enabled to bind probably to this domain, distributing interaction with NBD1, which causes the dysregulation of opening and closing channel, and the channel will not be able to open at all. So that will make as it will not function at all, even if we have the protein in the membrane.
Our mutation has two groups of symptoms that come from cystic fibrosis. The first is groups of respiratory systems, which can make it harder to breathe and circulate blood throughout the body and make things like exercise very difficult to do. And the second is digestive-based systems, which make it harder to digest and absorb nutrition from food. In respiration, specific symptoms include a persistent cough that would produce sputum, which is like a thick mixture of saliva and mucus, as well as a lot of wheezing. There will be frequent and sometimes severe lung infections that can lead to permanent damage. There will be frequent inflammation of nasal passages, which can also be called getting a stuffy nose, and recurrent infections to the sinuses, which is also known as sinusitis. Specific digestive related systems include steatorrhea, which is the production of a foul smelling greasy stool, which can be caused when your feces has an abnormally high amount of fat in it. And due to the lack of nutrients absorbed by the body, it can make it very hard to put on and maintain weight and increase your size, especially for children. It can cause the inability to pass stool, which can lead to other issues like intestinal blockages. And it can even cause chronic or severe constipation, which may include frequent straining while trying to pass stool, and can eventually cause part of the rectum to protrude outside of the anus, which is known as a rectal prolapse. Next slide.
For the
7
treatment,
minutes now, so.
yeah. So we don't have 100% medicine for this mutation, but we have aminoglycoside. What it does when it's this is the normal mutation, and when it's got to UGA, so that's stop codon, so release factor, it will work, and the protein will not be will not form. And in these two pictures, we see that the gentamicin it's combined with mRNA ribosome complex, causing conformation change that leads to the ribosome to miss mRNA stop codon, resulting in adding or nearly addition tRNA to bind, thereby avoiding to premature termination. So in this case, at least it will not read the stop codon, and that's it's used for short time, and it's not good for a long time because it's toxic. And there's another treatment, but it's clinical trial. Trikafta and Symdeko with Trikafta, Avocator with Trikafta. So there is some result that show that the two patients that have the mutation W1282X has shown benefit for ivacaftor treatment. Thank you, everyone.
Thank you.
Thank you. And this is our sites.
Okay. Thank you, everyone. We've gone a little over the end of the class period, so if you need to leave, please do. But I would like to thank all the groups and all the participants. You've done a lot of work, and I really appreciate that. I hope that it's been a learning experience for you, both about this disease and about how you go about preparing a presentation. And I'd like to say one more thing, and that is if you have any comments or suggestions about this project and how it was constructed logistically, please let me know, because I'll probably be doing this again in the future. And if there are ways to improve it, I would like to do them. Aside from that, just remind you that a week from today is the final exam. So any questions or comments at this point? If you have suggestions about the project or the course, send them to me by email.
We don't have Zoom for the final, right?
No, there's no class meeting.
Is it going to be available all day or just a certain period of time?
Yes, it'll be available all day. I haven't prepared it yet, but my thinking is to keep it relatively short for a final exam and limit it to one attempt.
Okay.
Will there be a Zoom on Monday?
No, Monday's a holiday, so there's
That's right.
no class.
Are the project grades going to be posted today or later on this week?
Later this week.
Okay.
Okay, anything else?
Are you going to have office hours today?
Yes. Okay. Scott, do you have anything?
I don't have.
Okay, well, Scott will have, will you have workshop hours today, Scott?
I can.
I think his mic's cutting out.
Okay, well, he said I can, so he will be having his workshop, and I will have office hours at 4 o'clock. Okay, you can always communicate with me by email or with Scott, and I'll see you at the final.
Sounds good. Thank you for an awesome semester.
Okay.
Likewise, yeah.
Thank you, Professor. Have a good day.
Okay, thanks so much.
Have a good one, man.
Appreciate it. Bye.